Thank you. Good afternoon. We call this in England the graveyard slot. Immediately after lunch, when the juices are flowing and all the blood's diverted. But a little shake of the limbs and I'll try and wake you up. It's actually a great pleasure to be back in Finland. On the previous occasions I had cause to be here working in Finland, I was actually partnered with Niilo, who's the speaker immediately after me. And we were collaborators in a very large European project that we'd managed in England to give the name of Galen or Galen, which Niilo then pointed out essentially meant mad in Finnish. And we actually did run a more or less mad European project for 3 or 5 years. And what's either reassuring or depressing, I'm not sure which, but here we are now some 10 years on. And all the difficult problems are still the same difficult problems. What I'm going to share with you over the next 25 minutes or so are very much, it's a synthesis of experiences over many years in this field, from a clinical perspective, as a practitioner, as a researcher, working in industry, both in Europe and the US, and then perhaps most recently, for 4 years, I was an executive director of the NHS Information Authority in England, and I was very involved at that time in the start of what became this large national programme in England. I think it's no secret that around the beginning of 2004, I excused myself from that because my views weren't altogether those of the dominant orthodoxy. But what I'm about to share is not specific to any of the things I've worked in. But I hope it is a synthesis of what I have seen and observed in many areas. Particularly, I've probably had more experience of what doesn't work than what does work. And I've even had experience of things that could never work. And yet, somehow we all manage to still press ahead and try and do them. In listening to this morning, and very impressive and fascinating, I was thinking, what's the main difference between that and what I'm about to say? And I suppose it's this. The introduction of information systems into IT, into healthcare is important. But there's something about when you get beyond it being a system to run an institution or an organization, and you're trying to create something that is part of a societal infrastructure or part of the fabric of the way health is conducted, a lot of issues come into play, a lot of complexities and considerations that become very challenging. And certainly, if you take the National Health Service, for example, it's a strange animal. On the one hand, it's an organisation with over 1 million employees that runs lots of hospitals and so on and so on. It delivers care. But it's also this guardian of health in the country. And I think one of the issues it has at present is it's got those two distinct roles, really, a bit confused. So a lot of what I'm going to talk about here is how do you deal with individuals and their health, which will be evolving over time, may involve diverse providers and provision. How do you keep that coherent and sensible at a societal level almost, in the face of what could be potentially a very changing environment on the provider side? So this is what I'm going to try and cover. And a theme that I'll keep returning to is this question of design, and by that I mean healthcare design. I'm going to characterise very crudely the approaches I've observed over the years, say something about an approach I think as a model has great merit when thinking about issues such as what does a country do, some of the benefits of that, and then I've also been asked to say a little bit about some current situations. Now, this does not follow exactly the slides you have in your books. I think most of the key slides are there, but it's been shortened a bit because of the time, and I'm also going to say a few things about specifics. We've heard a lot about this morning, in effect. Modern healthcare is paradoxical. We've never had greater ability and knowledge. We have never expended more resources to the point we are running out of them, people, money. And yet, in many ways, the gap between what ought to be possible and what happens has also never been bigger. And we've heard about that on the macro level with the 98,000 avoidable deaths. That muddle and confusion is the 8th largest cause of death in the United States, or on the micro level. So that's familiar to all of you. We know why. This is based on real work in the UK. The detail doesn't matter, but even for a very medical model of care, forget for the moment the social issues and the social services involved and the self-care and the daughter-in-law who looks after them. Just pictures like this and the biomedicine that's involved in that has completely outstripped our ability to manage people through these sorts of situations. I love this quote. Again, it's from the study that Larry mentioned this morning. This isn't just because people don't care or are stupid. It has become not possible. And this marvellous phrase, the ways care is organised. And I would argue that our discipline really here is the discipline of the ways care is organised. How do we go about managing people in this increasingly complex world? And the first thing not to do is to drop down into some technological or architectural design. You have to have some sort of healthcare design, some picture explaining how people are going to get cared for. And if I had one message from my experiences, is that the lack of that cripples information programs. What you find is that people try to solve this problem in a database design meeting. And the information program collapses and the wider change program collapses. So I'm just going to take you through an embarrassingly simple approach. But I actually make no apologies because complex problems only ever have simple solutions. The trouble is to find the right simplicity. Healthcare is not made of institutions. The National Health Service, the institutions of the National Health Service were reformed 18 times in 20 years. People ask, how could you not get it right? What that tells me is it just didn't matter. It could not have been making any difference to what happened because you could not make 18 changes in 20 years if it actually mattered. So special health authorities come and go, trusts come and go, everything moves around. It's mainly the same people. Whatever they do, you roughly end up with one national body, 10 regional bodies, 100 below that, and then about 1,000 things below that. And they've all had different names over the last 30 to 40 years, but the managerial superstructures have followed that. So you can't fix the healthcare system by fixing the institutions. Healthcare is just individual experiences. It's all the stuff we've heard about this morning. It's people seeing clinicians, it's seeking care, it's what happens by hospital beds, in clinics, in homes, in pharmacies. So the approach is to try and fix the healthcare system by fixing the individuals. Now there's a problem there because if I said in the room, so who in the room is responsible for the individuals? There's probably not many people put their hands up. And this is a challenge when you're trying to do things like create information systems and get people to pay for them. So I'm going to take you through a little set of pictures, but at the heart of this always is this idea of the care of the individual seeking help and advice. Three things come together when this happens. Now this may be as simple as going into a pharmacy for a tablet, it may be as complex as having brain surgery, but three things always come together. There's the individual, the patient, with their history, experiences, wishes, needs, preferences, dislikes. There's usually some sort of expertise, and I'm not limiting this to formal expertise, doctors. It could be relatively informal. We have heard about the problems of there's just not enough doctors going to be on the planet. Certainly in England, when the capacity was looked at, to carry on as we are, we would need between 15 and 20,000 more doctors. And even when the politicians thought, well, all right, we'll pay for it, it was then explained to them it would take 15 to 20 years before we could even make any significant dent in that. And that's really what led to IT being funded in England. There was no option left. So care providers, and then finally facilities and resources, maybe as simple as a desk, it may be as complex as an operating theatre or laboratory or whatever. From the point of view of the individual, this is England, so it's Mrs. Smith. In terms of the healthcare system from her perspective, it's not health authorities, trusts and boards and executives and integrated delivery networks. It's just the people and the places that Mrs. Smith deals with. A variety of providers spread over time. This is just the picture I was showing you before. In terms of information systems over the years supporting this picture, perhaps the best established types of systems were there to run the first perspective, the facilities and resources. So we have systems that are very good at managing beds, managing tests, managing rooms, managing schedules. And these are some of the most mature systems we have. Later, through the pioneers in the 70s, then through the 80s into the 90s, we started to see tools and systems to help clinical tasks, to prescribe, to manage the workflow, to do so on and so forth. And then last but not least, we've now also turned our attentions to the Mrs. Smith's problem. How do we ensure that the care is coordinated? A institutional system, a hospital system or a general practitioner's system, covers some part of that picture. Typically it will manage the resources in the institution. It will provide varying degrees of functionality for the care providers, but often is only concerned with that bit of the individual that's immediately in their caring. And that's a typical sort of footprint for the systems that are familiar to us now. What that means is there's still this kind of, we've systems to run everything except Mrs. Smith. How is that to happen? And the problem we get is that instead of it looking like that, it tends to look a bit like that as Mrs. Smith goes through her experiences. So what to do about that? I'm now going to go through three broad approaches. First, two extremes, and I emphasize these are caricatures, but many activities have characteristics of this. One approach is to take a system, in some sense, that manages an institution and just make it big enough. Now, just make clear, I'm not talking here about even the things we heard this morning around healthcare systems. I'm talking here trying to do this for a country, where in some way you want to construct one giant logical system, which is everything that could happen anywhere, ever to everybody, and not just the data, but the processes. I would argue I haven't yet seen an example anywhere where just everything that happens is somehow part of one grand scheme in a tightly coupled way. I'm going to argue against that for the moment. The other pole of this issue is where people have looked at the first picture and gone, that's too difficult, that's impossible, we can't get agreement, or there isn't enough money, or the competing hospitals will never work with each other, for whatever the reasons. And a magic word is used, interoperability. The problem will be solved by interoperability. And the idea is that the institutions will all interact with each other and Mrs. Smith will be safe. The problem with this is interoperability is a good thing. It is very helpful that systems and so on forth can be interoperable. But you're still left with the question, where is Mrs. Smith? If I want to join this picture to help care for Mrs. Smith, where do I go? Who in this picture is concerned with their journey. I'm going to reject that. I put to you that it's really quite important to understand this difference between running institutions and running individuals. This is an approach of separating the overall design into two elements. This is something that's now being followed, for example, in Wales, and it was advocated in England, though I'm not sure it's now what is actually happening, and it's being looked at by people in the United States as well. Split it into two pieces. The care management systems, which are those systems that manage the caring in the institutions, allow you to do the ordering, the scheduling, the noting of care, the capturing of ECGs, etc. And then introduce a new element that I call an individual health record, because just had to think of a new name because all the other names have been used so much, which is focusing on the overall care of the individual. And this last line is the most important line. Define just enough rules to start with for linking them together. In a very complex situation like where you're trying to put a system in a society or so forth, if you over-constrain the problem to start with, if you have too many rules, it simply will not work. What does that mean? Here's the individual. Information is needed, as we've seen this morning, to make better decisions, better care. Things happen within that care, be it in the pharmacy or the hospital. Events happen which change the individual's state of health, things which have to be known. As was well put this morning, if you do something to somebody and keep it a secret, that is a really bad thing to do. The institution-based systems, these care management systems like the GP system, if they exist, and there are many people practicing medicine now who have no information system support at all, they are tightly linked to that care. They may manage the resources, support the prescribing and so on. And I propose you look at putting a second piece into this picture, this individual health record, which works together with the care management systems, but is separate from it. And the two work together to provide care. What does that mean? We've taken the problem apart slightly and said, I can't solve it all with one giant system. I can't solve it just by letting systems talk to each other ad hoc. There has to be something there, which is the point of coordination across all providers and time around this individual, and place it within the environment. What does it do? It's there to support the care of the individual. And that's very important. It isn't there to do everything. It should focus on the information and the processes of most importance to the individual's care. It doesn't have all the information, anything ever recorded anywhere. That really is not necessary, nor is it possible. But what it must do is bring that information together. The task is not just to get the data in one place. The task is to understand that information, to know that a piece of information from one place, when taken with a piece of information from another, has immediate significance. And that can't happen if all you're doing is just assembling data. As I've said, it doesn't actually have to contain anything ever recorded anywhere. It doesn't have to have 300 post-operative blood pressures to be helpful 2 years down the line. It needs to be used by not just professional carers, but also the person themselves. In terms of the other piece of the equation, the yellow boxes, the care management systems, these are an institutional responsibility, and actually the institutions may be separate legal entities that you're trying to work with. And don't get the impression the NHS is one organisation. It is not. And private provision of healthcare in England is increasing to NHS patients. So NHS patients are increasingly getting care from private providers. So it's becoming increasingly difficult, even in England, to say that all the institutions can be controlled in any simple way. That is no longer the case. They manage and document the detail of the caring itself. They're vital, as we've heard this morning, to improving clinical processes, and they work with the overall health record. So they go together. You will have many different sorts of systems now and in the future in institutions. And one of the really hard problems is, how do you start from where you are? Are you going to go in and take out every system in the country and replace it with something before you start? Or are you going to try and start on things that matter and gradually over time make decisions about those other systems? These are really important decisions and debates. The individual record then comes in and provides that support to the side, both for overall individual care and as a safety net when either one of the yellow boxes is not working or just doesn't exist or is being replaced. This is the sorts of information I'm talking about. This is based on extensive work with clinical groups in the United Kingdom, whose leadership fully supported this. And it's the obvious things. You start with just knowing who somebody is and how they wish to be dealt with, through to the important care relationships. Who's involved with their care? People said, if you could just give me a name and a phone number, I would be much better off than I am now. Then to the information from the events, getting more sophisticated, the reports, and so on, that come from the health encounters, procedures, treatments. And then finally pulling that together to understand what is their current medication problems, alerts, allergies, and so on. So again, very familiar materials, but managing to keep this together in a complex environment. How is it obtained? Well, certainly in the case of Wales, we're going to start by using what we have, exploiting existing systems and processes, existing communications, things that exist now. Most of the information I have shown you exists somewhere on a system electronically now, in most of the UK. Most of it is not available at the time of care in most other places. How will it be used? Again, a mixed approach, allowing for the fact that people will be in very different situations, starting from very different places. So the goal is to integrate these, so somebody isn't using two systems, they'll use the system they have, it will just know more about the patient. So integration is important, but also providing direct portals to use this, and particularly for the individuals themselves, for the patients who have nothing now. And these two strategies can run in parallel, they can run at the same time. We don't have to get everybody to do exactly the same thing at the same time. It's unrealistic. Control. We could spend a whole morning on the subject. These are certainly the principles being adopted in Wales. The information belongs to the individual. It does anyway, and I can't see who else it could belong to, given this exists outside any single institution. There's the idea of the custodian. In the UK, this would be the NHS, but somebody who cares for it on their behalf, makes sure that it's properly looked after. It's available for those providing care. And this last point is very important. Privacy confidentiality will only be managed if it's aligned with how care is given. It's very peculiar how information is dealt with as if it's some foreign land. Professional people are trusted to give you tablets, drill holes in your head, cut you open, and yet when it comes to information we get ourselves in terrible knots over how to manage that. So you just must align it with the general principles of care, how care is given, and the trust that exists there, and exploit existing sources of authority. Don't invent completely new ways of trying to regulate the medical profession. These are some of the implementation maxims we created, and they're pretty obvious, but I'd point out the last ones. Giving people confidence that this stuff can help. Not saying to them all the time, at some point in 10 years' time, a wonderful miracle will occur and we will all be in a new land. Start with something for everybody. Win that support, win that confidence, but at the same time ensure it's strategically sound. What that means is, and if you take the case of the NHS in Wales, you really have two strategies running side by side. The top one around this individual health record is about that public infrastructure for health. It's outside of any particular institution. It's how things need to be managed in the country. And that can grow on its own trajectory. At the same time, you can develop your strategy for those hospitals and clinics that you're responsible for what to do about specific systems. And there are very, very strong arguments for using common systems there. Training, safety, familiarity, value for money. They are very strong arguments, but they are different arguments to the arguments at the top. And if they get confused, and I have seen them confused many times, a terrible model results. As I said, that, for example, is currently what we're following in Wales. I've been asked to say a little bit about England. I've declared my interests at the beginning, but I shall try and give you, to the best I can, some insights into what is happening. Most of this is probably known to most of you. In 2003, a very large procurement was run in which the country was, and this is only England, was divided into five clusters, and local service providers with a solution set were brought together, and that was the result of the companies. Originally, the north of the country is to use a solution from a company called ISOF that is currently under development. The bottom was, everybody was to use IDX, but recently you'll probably have seen that in the south, Fujitsu have dropped IDX and brought in the Cerner Corporation. The intention, and most of this hasn't happened yet, was to have a large-scale deployment of new or replacement systems. So much of the integration was to be achieved by replacing all the systems. The idea was that each of these coloured zones would in effect have one record, one system across each of them. And all of that would be being joined up through another national piece. There's another national supplier through a transaction spine with messages. And there continues to be a debate on what, if any, and what any summary record will look like in this picture. And as much as it's possible to tell, I think this is probably closest to my approach a systems, institutional systems view of how to do this. And if you follow the developments in England, there's a great deal of debate about, is this going to work or not? I think it's also fair to say that a lot of the clinical community is still very sceptical and feels somewhat left out of this process. But we watch this large experiment with great interest. Just a few words on the USA. Some of you again may know that this concept of a regional health information organization is popular. Local groups come together and agree to interoperate. I think that's closest to my approach B, institutions exchanging information. Sometimes these early Rios look a bit like a peace conference where warring factions come together and decide not to quite fight as badly over this issue. I still find it hard to understand how the individual person will materialize from these activities. But again, interoperability is necessary. It's just not, in my view, sufficient. And as been mentioned this morning, there's proposals have been put into the national coordinator for how this could be done on a nationwide basis, and we await the results of that. And the things I've talked about, there's some groups proposing that sort of approach. So to conclude, reiterate the point that however you go about trying to solve this problem, you have to have some basic design for how people will get cared for in your healthcare system and what really matters within that, what information or processes. You have to have a way of deciding that. If you don't, you'll be overwhelmed by the complexity of the situation and the stakeholders and the challenges. I'd advocate you start from individual care, but do that seriously. Don't just pay lip service to it. Actually architect things that really represent individuals in the environment. I like the idea of making this distinction between individuals and institutions. I've talked you through that approach broadly. And one of the things I would say, it's an attempt to find an incremental and flexible way of what is otherwise, as we say, rather like trying to eat an elephant. And if you try to swallow the elephant whole, it just won't go. So find a bit of tail or a toenail or an ear or something you can get your teeth into and start to take the problem apart. I think that's it. Thank you.
Thanks a lot, Anthony. It was extremely helpful in kind of for structuring our thinking, and I'm looking forward that this discussion will continue with the Finnish planning and your experiences also in Wales. Are there immediate comments? Yes, please. Kari Harno needs a microphone. Just a second.
Thank you very much for the ideas. One question. How do you intend to bridge the gap between the present system design and what you are intending the individual health record? What is the intention of sort of going and not confronting the digital divide solution, which is certainly facing you, because this would be a major issue, how to solve the problem of the digital divide between different persons.
When you say digital divide, do you mean for individuals in society?
I mean the individual within the society, right, because differences certainly exist within it.
Yes. Two points. First of all, to begin with, regardless or not whether the individual themselves starts to make use of this, it is very, very valuable, I'd argue, for their care. So one of the immediate benefits to people is that their care can be improved in a reasonable way. Now in Wales, for example, a programme of work has begun to understand better how people will get the benefits of this. And the benefits don't have to be as simple as will they or will they not use a computer to look at something. Because as was said this morning by Dr. Wiesenthal, we haven't yet got creative enough about how people will get the benefits from having information there. And some people may want pieces of paper, some people may want phone calls. We really haven't begun to understand when we say consumer-centric care what that will actually mean. But this is of benefit to people even before we get as far as them taking more control of their health directly. In terms of the practicalities of this, I think the main reason for this approach is to separate out the problem. So, for example, in the case of Wales, there's a strategy for the care management systems, and there's a strategy for this, and they can proceed to some extent in parallel. You're not waiting for one thing after another. You're not having to rip all the hospital systems out before you can do something, and then, and then, and then, and then. And before you know where you are, 10 years has gone by, and no single doctor or patient has seen anything that's different to what was there at that time. But there's no, I don't know, we will find out in 5 years' time when we are very, very surprised what people do with this record in 50 ways we never predicted.
Okay, one more.
Teuvo Peltonimi from A-Clinic Foundation. I do work with alcohol and mental health questions on telematics, and I really enjoyed your points because for me also often I feel that it's institutional or that we are improving office techniques in a way and not really looking for the patient. The only comment I do have is that most people, at least in our field, they also treat and care for themselves and for the peers. So the whole system should also perhaps a little strongly include self-help and peer help, because that's the complexity of the system where people are really situated.
Yes, the definition of provider in this model is anybody who helps you. It is not limited to what we'd think of as formal providers, self-help, peer help, and so on. Again, if you said to me, what exactly does that mean? I don't think we really know yet as to how this will evolve. But if you focus around the person and say, who do you want to be involved, and work from that direction out, I think at least we stand a chance of being inclusive. And we have to be, because the only last great untapped healthcare resource is the people themselves. Every other resource is exhausted. So we have to rely on people solving problems for themselves.
Okay, thanks a lot again.